Good evening, everybody. Today, the topic for the webinar is CSF Rhinorrhea. I'm Dr. Lavanya, consultant otolaryngology and head and neck surgery, Bangalore Head and Neck Sciences. So we'll start with the topic without further ado, and people who join can continue from where they've started. Okay. So we'll begin with what is CSF Rhinorrhea. CSF fluid. CSF Rhinorrhea is nothing but CSF fluid that results from a direct communication between the CSF containing the subarachnoid space and the mucosalized space of the paranasal sinuses. As you can see here, so generally the space has multiple layers. So when there's a defect connecting the subarachnoid space and the sinonasal cavity, the mucosalized space of the paranasal sinuses, there's leak of the cerebrospinal fluid through this defect into the sinonasal cavity. So this is known as CSF Rhinorrhea. But why is CSF Rhinorrhea important? What happens if there is CSF leak through the nose? So our main concern with CSF Rhinorrhea is not per se the CSF leak itself, but because of these persistent dural fistula, there's a persistent hazard for meningitis, other intracranial infections, pneumocephalus, and brain compression secondary to this defect. So these conditions can be extremely fatal, and this is our priority. So why we have to consider CSF Rhinorrhea and treat it immediately is because to potentially avoid these hazardous complications. So we'll start with some of the basics. We'll start with CSF circulation. As you can see here, as we know, the CSF circulates within the skull, cushioning the brain. So from the lateral ventricles through the third ventricle to the foramen of Monro, and from the third ventricle to the fourth ventricle through the aqueduct of Sylvius, and then into the central canal, and through the lateral aperture, that is foramen of Lashka, into the subarachnoid space. So generally the CSF is produced from the choroid plexus mainly, and then absorbed through the arachnoid granulations. So the rate of production of CSF is 20 ml per hour. At any given point of time, there's about 150 ml of CSF. So the turnover every day is around 3 to 5 times. So the normal pressure is 5 to 15 centimeters of water, and anything exceeding 20 centimeters of water is known as increased intracranial pressure. So, but the pressure is not constant throughout the day. So it can vary between 5 to 15. With the time of the day, the age of the individual, the activity level, and the cardiopulmonary activity. So what are the main functions of CSF? So it mainly acts as a source of nutrition for the brain. It helps in the process of excretion of the metabolic waste products. There's intracerebral transport medium. It also acts as an auto-regulation of the intracranial pressure. And one of the more important aspects is the protection aspect that basically acts by absorbing the mechanical energy in case of any traumatic event and provides buoyancy. So we'll move on to the main topic for today, that is the CSF Rhinorrhea. So starting from the beginning, what are the causes of CSF Rhinorrhea? So they can be broadly classified into traumatic causes and non-traumatic causes. Traumatic causes can be accidental, it can be immediate, or it can be delayed. Also, the trauma could be because of surgical complications. When we're talking about surgical complications causing CSF Rhinorrhea, generally two different procedures are involved. One is the neurosurgical procedures and one is the rhinological procedures. In neurosurgical procedures, the transsphenoid hypophyseectomy, any approach to the frontal craniotomy, and other skull-base approaches. We're talking about the rhinological procedures. We are looking at endoscopic sinus surgery, septoplasty, and other skull-based procedures. When we are looking at non-traumatic causes of CSF Rhinorrhea, there generally is an elevated intracranial pressure. This could be because of an intracranial neoplasm. It could be hydrocephalus. In hydrocephalus, both non-communicating and obstructive hydrocephalus can cause increased intracranial pressure leading to CSF rhinorrhea. One of the more important and condition that we will be discussing in more detail is the benign intracranial hypertension. There's also normal intracranial hypertension. There can be congenital anomalies, skull-base neoplasms, including the nasopharyngeal carcinoma or sinonasal malignancy, and skull-base erosive process such as sinus mucosal osteomyelitis or idiopathic congenital skull-base deformities can be present. So here we'll be talking in detail about the benign intracranial hypertension in non-traumatic causes, and in traumatic we'll just look at some of the basics here. So one of the more important aspects is to know where the CSF leak is from, where the CSF rhinorrhea is occurring from. So according to this recent paper about the diagnosis and localization of the cerebrospinal fluid rhinorrhea, so they found it was a systemic review paper. So we have majority of the sinonasal leaks from the ethmoid roof. The next most common is the cribriform plate. So sphenoid sinus, frontal sinus form a minority, and other areas are very small in number. They form less than 9% of the cases recorded. So most of the cases we also commonly see is either from the ethmoid roof or the cribriform plate. And the approaches to treat the defects in ethmoid roof and cribriform plate are of more importance than the other conditions. And we'll be discussing that in more detail. So if we look at traumatic CSF leak, so generally the traumatic CSF leaks are more common from the anterior skull base. And this is mainly due to the firm adherence of the dura to the anterior skull base. So generally, most commonly, the traumatic CSF leak are from sphenoid sinus and frontal sinus, followed by ethmoid and cribriform. Ethmoid and cribriform form 23% of the CSF leak, and then temporal bone. Okay, so temporal bone CSF leaks are very minor, and most of them can also be CSF otorrhea. So here, in traumatic, sphenoid sinus, frontal sinus is more common than the cribriform and ethmoid. But when we're talking about traumatic CSF leak, not all of them will be immediate and appear immediately. More than 50%, but more than 50% of the traumatic CSF leaks are evident within the first 2 days, that is the first 48 hours, and more than 70% of them appear within the first week, and almost all the traumatic CSF leaks appear within the first 3 months of time. So the delay between the first few days up to a week to up to even 3 months could be because of the initial inflammation and edema that plugs the defect, or later on the defect leading to resorption of the bone and soft tissue causing the CSF leak, disrupted blood supply, or a weakening in the pyoarachnoid seal. So in the recent times, iatrogenic CSF leak is catching up with the traumatic CSF leak percentages. So some of the common procedures that we saw was the neurosurgical procedures and the rhinological procedures. So whenever we are doing surgical procedures in endoscopic sinus surgeries, generally we have the cribriform ethmoid area in 80% of the cases is what gets injured. The frontal sinus and the sphenoid sinus are an extreme minority. And whenever we are doing an aggressive middle turbinate retraction or resection, or whenever powered instruments are used, that can also cause iatrogenic CSF leak. So not only knowing the anatomy, but extremely careful dissection is of utmost importance to avoid iatrogenic CSF leaks. So in neurosurgical procedures, any transsphenoid approaches can cause a CSF leak. So here the most common site is sphenoid sinus. So we look at non-traumatic causes. We generally see non-traumatic CSF leaks in adults generally in the 4th decade of their life. So generally it is more common in the female, twice as more common in women than in men, and may occur as an episode of either coughing, sneezing, or straining, or it can be completely spontaneous. So major factor in non-traumatic causes for CSF leak in adults is raised intracranial pressure, but the cause for the raised intracranial pressure can be varied. One of the more common causes is the intracranial tumors, more commonly pituitary neoplasms. It can be hydrocephalus, both communicating and obstructive. Benign intracranial hypertension, also known as idiopathic intracranial hypertension or pseudotumor cerebri. So we'll look into benign intracranial hypertension in slightly more detail. So BIH or benign intracranial hypertension is nothing but a syndrome of increased intracranial pressure in the absence of specific causes. So after a complete history, examination, and radiological evaluation, we cannot with certainty say the cause for increased intracranial pressure, or everything else seems to be normal and we can't pinpoint a cause. In those cases, we call it as benign intracranial hypertension. So wherever there's no intracranial masses, there's no hydrocephalus, dural sinus thrombosis, or any known cause. So generally, it is more commonly seen in middle-aged women in their fourth decade and generally who are obese. Whether obesity has a direct relationship or not, there are multiple theories regarding it. So generally, a patient will present to us with headache, pulsatile tinnitus, papilledema, and visual disturbances, including abducens nerve palsy. Okay, so more commonly, individuals present to us with headache or pulsatile tinnitus. Some of them can have visual disturbances like visual snow, floaters. So these, when we further examine them, there can be papilledema in these individuals. Some of them do end up with the ophthalmologist first before for raised intracranial hypertension before they develop any other symptoms. So if you look at the causes, is it the female gender? If you look at female gender, then we have to look at the hormones and endocrinopathies. If you look at obesity as a cause, adipocytes, so where cytokines, adipokinosis, or vitamin A deficiencies can be some of the related causes. But why does increased intracranial pressure occur? Either if the pressure has to increase, either there has to be more production or decrease in the drainage. So, or the balance between both of them is disturbed. So we exactly do not know the certain cause here, why, whether the CSF production is raised or the CSF drainage is decreased or not. So more of the theories go towards decrease in the CSF drainage, where the arachnoid granulations do not follow the absorption pattern in normal individuals as in these individuals. So there are certain criteria that we need to be aware of to make the diagnosis of benign intracranial hypertension. Initially in 2002, it was the modified Dandy's criteria, which says that any symptoms or signs must be solely attributed to intracranial hypertension or papilledema. There should be documented elevated ICP and normal CSF composition and normal neuroimaging, and no other cause for increased intracranial pressure should be found. But in 2013, the guidelines was revised, and the present guideline says that it is a must for papilledema feature to be present. Normal neurological examinations, except for cranial nerve abnormalities, normal neuroimaging, normal CSF composition, but with the CSF opening pressure of greater than 250 mm of water. Okay. So anything about 25 centimeters or 200 mm of water was known as increased intracranial pressure. Here the criteria is greater than 250 mm of water. If papilledema is not there in an individual, but rest of the features are there, then they must have either of these criteria, okay? And the neuroimaging mainly. So either empty Sella should be there should be flattening of the posterior aspect of the globe, distension of the perioptic subarachnoid space with or without the tortuous optic nerve, or transverse venous sinus stenosis. Okay. So either empty Sella, partial or complete empty Sella, flattening of the posterior aspect of the globe, distension of perioptic subarachnoid space with or without tortuous optic nerve, and transverse venous sinus stenosis. So we'll also look at what empty Sella syndrome is. Its a clinical presentation is very similar to benign intracranial hypertension. Here also the individual presents to us with headache, memory loss, cerebral ataxia, papilledema, and other visual field defects. So you can see in the diagram here, the CSF is normally present and the pituitary occupies the Sella turcica. When the pressure increases, the CSF gets pushed into the Sella turcica and it displaces the pituitary gland. So there are various anatomical factors that we need to take into consideration because these are generally defects. Either these defects could have been iatrogenically caused, they can be other accidents or traumatic events, or sometimes these are congenital anomalies. So one of the most common areas of these defects is the lateral lamella of the cribriform plate, so which has been recognized as a potential area of weakness. So whenever there is any increase in the intracranial pressure, the lateral lamella of the cribriform plate is one of the most common areas to be affected. There can also be congenital dehiscence in the lateral sphenoid roof. This is because the lateral craniopharyngeal canal, that is known as the Sternberg's canal, could have a role in this. So congenital dehiscence of this can cause a defect in the lateral sphenoid roof, causing meningoencephalocele and CSF leaks. So any thinning of the bony skull base because of the pressure from the overlying intracranial contents coupled with constant dural pulsations, okay, may further erode these weakened areas if they are already present, resulting in CSF rhinorrhea. So we look at what the clinical presentations are. So patients typically come to us with complaints of watery discharge from the nose, more commonly one-sided than both-sided, and generally they say that it is clear and is sometimes present as a gush, or if they lean back and lie down and when they bend forward, there's a gush of the fluid coming out. That is when the drainage increases on either leaning forwards or when they put any pressure, any amount of strain, like picking up heavy objects or sneezing. So other symptoms can also be, like we discussed initially, symptoms of increased intracranial pressure itself. So that is headache, vomiting, vision changes, visual field defects, salty taste, anosmia. And we always have to inquire about any previous surgeries, any traumatic events that was there in this individual's past. So when we are looking at the diagnosis of CSF rhinorrhea, when we suspect a CSF leak, we have to confirm two things. One, whether it is CSF, and two, where is the site of leak from. So to confirm whether it is CSF or not, we either look at the clinical history and examination followed by the laboratory findings for confirmation of the CSF. And to confirm the site of the leak, we look at radiological examinations and endoscopic examinations. So starting with the clinical examination, there are a few tests which can be done bedside to determine if it is CSF or not. One is the Kukendes test, where we apply pressure on both the jugular veins. This causes increase in the intracranial pressure, which further increases the CSF rhinorrhea. Okay. So other one is the reservoir test. So as soon as the patient is lying down for some time and they immediately get up from their bed, so we ask the patient to bend forward and the fluid is collected onto a paper. So here we see the clear fluid dripping from the nose whenever the patient gets up from a lying down position. So whenever they are in lying down position, the leak gets collected, and when they bend forwards and when they get up, this leak is pushed out and we can see. So this is known as the reservoir sign. So halo or double sign is the similar procedure where we ask the patient to bend forward and collect the CSF leak into the tissue paper. So if you see, if there is blood involved, there will be blood at the center and around it a clear ring of fluid surrounds. So this is known as the halo or the double ring sign. Okay, this will not be there if you're looking at conditions like allergic rhinitis, okay, where patients can also have rhinorrhea. Other one is the handkerchief test. CSF, when collected on handkerchief, will not stiffen it, unlike nasal discharge due to allergic rhinitis or a common cold. Because they have mucin and CSF does not have mucin, they can stiffen the handkerchief. So this is known as the handkerchief test. So if we are looking at the laboratory diagnosis, there's a glucose oxidase test, beta-2 transferrin, beta-trace protein. Okay, so one of the most commonly done and more easily available is the glucose oxidase test. So glucose oxidase stripes show color change on detection of glucose, but there is a chance of high, false, negative with glucose oxidase test. Beta-2 transferrin and beta-trace proteins are more sensitive and specific than glucose oxidase test. So if you look at beta-2 transferrin, The only other place beta-2 transferrin is present other than the CSF is the aqueous humor in smaller amounts. So this is one of the best tests to do to confirm the presence of CSF. The other is the beta trace protein. It's the second most common protein found in CSF after albumin. Okay, so it has been identified as a prostaglandin D2 synthase. So it has a 100% sensitivity and specificity in cases of confirmed CSF rhinorrhea. But if the patient is known to have a suspected or known to have bacterial meningitis or any renal insufficiency, then there can be false positive reports with beta trace protein. So in these patients, it's better to avoid beta trace protein and go on for beta-2 transferrin. So these are the tests that can confirm the presence of CSF. There's one more point that we should know is how to collect CSF. So generally, we ask the patient to have a sterile container and to collect the CSF fluid after they get up from a lying down position. So whenever it is continuous CSF leak, then it is easy for the patient to collect because generally reservoir sign also would be positive. So they can bend forward and the fluid alone is collected into the sterile container and immediately processed for testing. But if the patient has intermittent CSF leak, then this might not be easily possible. We have to wait to a point where the patient has CSF leak at a particular time and then do the test for confirmation of CSF. So the next important aspect, now we know that it is CSF, next is we have to know where the defect is or where the CSF leak is. So certain investigations that are of utmost importance and used to us is high resolution CT scan. So why HRCT, high resolution CT is of importance is generally these defects are bony defects in the skull base. So CT has a better resolution for us about the bony defects than say MRI does. So high resolution CT scans can give a very good idea of the area of the defect and the anatomy around it as well as the size of the defect. The other one is to do the CT cisternography or MR cisternography. So there are two ways to do cisternography. One is the invasive method. If you're talking about MR cisternography in specifically, where we inject a fluorescein. That is intrathecal fluorescein is one of the most common agents or contrast that is used when trying to diagnose sites of CSF leak. But to inject intrathecal fluorescein, a lumbar puncture has to be done and then it has to be injected and then the CT or the MR has to be done. Okay. So this is an invasive procedure. Not all the patients would agree for an invasive procedure, especially for a diagnostic purpose. When intrathecal fluorescein especially is known to cause complications. So patients can have allergic reactions, patients can have seizures with intrathecal fluorescein. So a strict monitoring and a pre-anesthetic evaluation is necessary before we go for intrathecal fluorescein injection for CT cisternography or MR cisternography. But with advancement in technology, actually we don't always necessarily have to do injection of the contrast for MR cisternography. So an MRI is done, a 3 Tesla MRI preferably, and CIS protocols are used to diagnose whether any site of CSF leak can be identified or not. So MR cisternography with CIS protocol is of utmost importance if you're not looking at invasive methods, but these have high sensitivity and specificity if the patient has continuous CSF leak or active CSF leak at the time of doing the MRI. But if the active leak is not there, then we might not be able to clearly identify the site of defect with non-invasive MR cisternography or the CIS sequence MR cisternography. So other than intrathecal fluorescein, what is option we have if we look at it? We have radionuclide cystonogram, where technetium-99 is injected and then a radionuclide cystonogram is done. Okay, where gamma cameras are used as the radionucleotide goes into the CSF and comes out. So at different time images are taken and then these can conclude how much percentage of radionucleotide is present, and that will give us the site of the leak. So this is the picture of high resolution CT showing the defect here. So this is a CT cisternography showing the CSF leak here. This is MR cisternography, where you can see the CSF leak. And this is intrathecal fluorescence, which is generally green in color. Wherever the CSF leak is there, it will be seen as this if we do an endoscopy in that patient. So intrathecal fluorescence can also be used during surgery to locate the site of leak. So we have looked at the clinical diagnosis. We have looked at what all is necessary to confirm the presence of CSF and how to confirm the site of the leak. So once we know it is the CSF Rhinorrhea and know the site of the leak, what is the next procedure? So for management, generally, there are two options. If at all it is an history of antecedent traumas, then it becomes either accidental etiology or it can be due to surgical iatrogenic etiology. So if it is accidental, after a consultation and there is no major neurological injury, and if we recognize it within 7 days of the event, we can do a conservative management and only plan for surgical repair if there is no resolution. But if the recognition of the CSF leak is after 7 days, then we generally go on for a surgical repair. If there is major neurological injury associated with the accidental etiology, then the choice is surgical repair. If it is iatrogenic because of surgical etiology, then if it is immediately we recognize it, we definitely have to go on for surgical repair at the time of recognition. If it is a delayed recognition, then we can try conservative management, and if no resolution, then go on for surgical repair. For non-traumatic causes of CSF leak, if say the patient comes with spontaneous onset, then we have to confirm the presence of CSF, then confirm the presence of the site of the CSF leak, and then preoperative defect localization has to be done, and then plan for surgical repair. If it is congenital, neoplastic, or inflammatory etiology, the etiology has to be treated first, followed by the CSF leak repair. So if you look at conservative treatment of cerebrospinal fluid rhinorrhea, so the main thing is we can do a lumbar puncture and put in a lumbar catheter and drain CSF slowly, less than 10 ml per 24 hours generally. The patient has to be advised bed rest, head elevation, stool softness to decrease the pressure, and the patient should be advised to avoid coughing, sneezing, nose blowing, or straining. Prophylactic antibiotics is a possibility, though Cochrane paper review says that there is no indication of prophylactic antibiotics to avoid meningitis. It has no role in preventing meningitis. So indications for surgery: any delayed or intermittent leaks that are there, any high pressure leaks that acts as a safety valve for hydrocephalus, or leaks that are associated with erosion, destruction, disruption, or combination of these at the skull base or the paranasal sinus regions, or if there are congenital anomalies that are identified at this point of time, or if there is recurrent attacks of meningitis in this patient. So generally, what do? We look at the broad steps, and then we will discuss a case study in detail, and I'll be showing you the surgical steps and how we do it in our center. So if you look at the procedure, we'll be looking at anterior skull base procedures here basically. So one is the endoscopic dissection and endoscopic exposure of the area of the defect and endoscopic repair. So here generally a standard endoscopic dissection of the paranasal sinuses is carried out till we can identify the site of defect and it is clearly visualized. Okay, this is an optional procedure whether a lumbar puncture is done with intrathecal fluorescent injection or not. If intrathecal fluorescent is injected, then at the site of leak, they would be seen as greenish colorized fluid that is coming out. So it would be easy to identify. It facilitates the identification of the defect, but it's not a necessity. Then the site should be prepared for grafting. Once the site is completely exposed, then the site needs to be prepared for grafting. Okay. Generally, for grafting, we enlarge the site until the bony rhythm of the skull base can be clearly seen. Then either bipolar cautery and even nowadays even coagulation can be used to fulgurate a concomitant meningoencephalocele. which should never be simply reduced by pushing it intracranially. So either bipolar cautery can be used or a coagulation can be used whenever we see a meningoencephalocele along with the defect. Okay? And once the bony rim of the defect has been identified and the nasal mucosa around the defect is stripped away for at least 5 mm, so that the graft we put can adhere to the bony area of the defect. So the graft that are commonly used is temporalis fascia, pedicled middle turbinate flaps, free cartilage graft, a free bone graft, autogenous fat. Okay, free cartilage graft and free bone graft are generally from the nasal cartilage and the nasal turbinate bones. So middle turbinate pedicle flaps are more commonly used. Nasoseptal pedicle flaps are also very commonly used. So autogenous fat is used in certain cases for bath plug technique of decreasing the defect, repairing the defect. So if you look at the grafting techniques, there's overlay technique, there's intradural underlay, extradural underlay, and then the bath plug technique. So these are broadly the major techniques that are more commonly used. So if we look at our center, we generally do an overlay technique. So most of the paranasal sinuses defects from the skull base, anterior skull base region can be corrected with an overlay technique. Okay, so this is the subarachnoid space, okay, containing the CSF. So there's a defect is here across the subarachnoid, subdural, epidural space, and then the bony and the skull base defect is there, and then it opens into the mucosa and the periosteum in the paranasal sinuses. So here what we do is we place the graft over the mucosa and the periosteum in the paranasal sinus area, okay, and then it is sealed. So it's reinforced here. So this is known as the overlay technique. If you look at underlay technique, there are two places to put an underlay technique. One is the intradural, where the graft is placed in the subdural space, okay. If you look at extradural underlay technique, the graft is placed outside of the subdural space, that is the epidural space, okay. So in intradural, the graft is placed in the subdural space, and extradural graft is placed outside of the subdural, that is the epidural space. So in bath plug technique, generally, as you can see in the diagrams here, plug of fat, autogenous fat is used, and it is pushed into the defect and then pulled out so that the defect is completely sealed by the fat. Okay, and majority of it would be in the intracranial part. So we will discuss one case that we had recently done in a Bangalore Head and Neck Sciences. So this was a 40-year-old female patient who came with complaints of spontaneous rhinorrhea on the right side since the past 6 months. So the patient said that it had spontaneously started 6 months back, more from her right side and never from the left side. So the initially at the point of beginning, the amount as well as the frequency of the leak was high. Over a period of time, it decreased, but then it would wax and wane at different periods of time. Okay. It was always clear fluid. Patient had no symptoms of allergy. Patient was not a known case of allergic rhinitis and no history of cold. And patient also did not give any symptoms of raised intracranial pressure like headache, blurring of vision, visual field defects, vomiting, okay, or any other infection. So we followed the routine that we have spoken about in the presentation so far. So we took a thorough history of the patient. All the comorbid conditions were taken into consideration, followed by routine examination. So we did a beta-2 transferrin and a glucose oxidase test to confirm the presence of CSF. And then we did a MR cisternography because the patient did not want to go in for any invasive procedure for diagnosis. Okay. Then following routine investigation, the patient was taken up for surgery. So here is the MR cisternography of the patient. As you can see at this point, I'll just pause it. So what the leak is in the frontoethmoid region. You can see the leak from this area if you follow that area. Okay, so there's a defect here in the right side of the frontoethmoidal region. Okay, so then we did an HR's high resolution CT to delineate the pony defect. So this is the coronal section of the HRCT. So as you can see, there's a defect on the right side here. It's meningocele, suspected meningocele. So after taking up the patient for surgery, patient was intubated and painted and draped. We did a nasal packing, and then we went ahead with the endoscopic sinus surgery, full house fest on both the sides, bilaterally. Okay, so we also intra-op did a Valsalva maneuver to confirm the presence of the CSF leak on the right side once the full house fest was done. So here, if you can see on the right side, the full house fest is done. So we're suspecting the defect to be on the frontoethmoid region here. So to get better visualization to this area, the patient, if you see in the previous scans, the patient has a huge conchobulosa on the, so if you see here, the patient has a huge conchobulosa on the right side. Okay. So what we wanted to do was, our plan was to use this mucosa from the middle turbinate as the graft. So here, if you see in the procedure here, you can see the resection of the middle turbinate being carried out. So the entire conchobulosa of the middle turbinate resection was done to gain better access to the site and also to use this as a graft. Here you can see the site of the CSF leak being exposed. So this is the meningocele. Okay. So here, after the site has been exposed, the entire area has been cleared. So the entire defect has been exposed in completely. So then we're packing it around with gel form before we plan for the grafting. So like I said, we generally, if a meningocele is seen, what we do is we have to either use bipolar cautery or we have to use coagulation. Most of the cases we use coagulation now. Use it on the meningocele and has to be reduced. We can't just push the meningocele back in intracranially. Okay. So here, once the meningocele has been reduced, here you can see the graft being placed. So this graft was obtained from the middle turbinate of the patient itself. So gel form is placed over the graft, the place is tightly sealed, and then tissue glue is placed on this area to completely seal the graft on the gel form in place. So here the video, you can see the technique to harvest the mucosa from the middle turbinate. So it's carefully, the mucosa is dissected off the middle turbinate with an elevator. Okay. So you can see from all sides of the middle turbinate. So this is the middle turbinate. This is the mucosa that you're seeing being elevated off the middle turbinate extremely carefully. Okay. So this is one of the techniques that can be used for graft, especially in patients who have huge conchobulosa. So this will yield a very big graft, that even bigger defects, this can be used even for larger defects. Okay, when we are looking at grafting for larger defects also, this can be used. Okay, so this was how we do CSF rhinorrhea. So the approaches and the plan for grafting will differ from patient to patient. So this was one of the latest cases that was done in Bangalore Head and Neck Sciences. So I hope we had covered some of the basics and the procedure in detail of CSF rhinorrhea repair. Thank you. So we can take any questions now. Okay, we'll end the session now. Thank you, everyone. Thank you. So you can unmute yourself and ask any questions you guys might have.
Hello.
So talking about transcranial approaches, we generally do not do any transcranial approaches here. So we mainly focus on skull-based approaches, and we generally do most of the CSF leak that we deal with can be treated with anterior skull-based approaches itself. So they have better visualization and better treatment options and less complications when we go endoscopically than transcranially. So we generally look at endoscopic approaches. Transcranial is necessary only when we are looking at extremely large defects and the posterior defects more commonly. If when we are looking at anterior defects, generally most of them can be dealt with endoscopic, anterior endoscopic approaches. Oh yes, my bad. Actually, so your question based on whether we do medical therapy, yes, definitely. So whenever we are doing a CSF leak, especially in such patients where we are suspecting spontaneous leak and we can't find any other cause for the CSF leak, post-surgical process, once we evaluate the patient pre-op, we give them a neurology opinion, we get a physical test done to ascertain if the patient is having any cause for intracranial hypertension. If we can't, if we are suspecting benign intracranial hypertension, then we start the treatment for that, and generally post doing the surgery to decrease the pressure as well as to allow time for the graft to take up and heal, we generally put the patient on acetazolamide for a period of time.
I can ask a question. Is that okay?
You can ask any of the questions that you have.
Okay.
Or
So I am a neurosurgery resident from Kenya. You can hear me?
yes, sir. One second. One second. Yeah, Kate, could you please repeat your question? We had a small glitch.
Okay, all right. Yes, so I wanted to share a case of a patient who's been followed up in a neurosurgery clinic in Kenya.
Okay.
I am a neurosurgery resident, yes. So
Yes.
the
Thank you.
patient is like a 54-year-old lady. She's been on follow-up in our clinic.
Okay.
Had an anterior skull-based tumor, probably an olfactory groove meningioma, which we
Okay.
resected transcranially.
Okay.
And she's been follow-up. It was a WHO grade 1, so it's just been on follow-up in the clinic.
Okay.
However, she's been having intermittent CSF Rhinorrhea,
Okay.
just from one of the nostrils. I think the right side. It's not large volume. It doesn't bed the. It doesn't cause excessive. It's not an excessive leak.
Okay.
By how she's able to quantify it. It doesn't wet her beddings. She's been resistant against doing a repeat surgery just to check if where the leak is coming from. We've not been able to do a high resolution CT scan just to delineate where the defect is. And I don't think we have the resources to do an MRI cysternogram.
Okay.
So we've been just treating her with medical therapy on acetazolamide. I think she's done it for like 3 months now.
Okay.
The
Has she
CSF right
improved?
now, she's not improved significantly. She still reports the leak, though it's much when she bends down. However, it's not that a lot. It's not so much. So in view of the risk of meningitis, because of this
Yes.
prolonged CSF leak,
Yeah.
and she has been resistant against repeat surgery just to explore where the defect is. What would be your opinion in such a case?
So, without the resources, it's definitely difficult. Is it possible to do a regular MRI?
We can get an MRI,
Okay. So
though I
generally,
don't know
what
if we
we
can get. I don't think we can get the CIS protocol or the Fiesta. We can just
okay.
get the normal sequences.
Okay. So generally, 3 Tesla MRI, if the patient is having an active leak at the time of MRI, can definitely help us identify the site of leak. That would
Okay.
also work if this is
Mhm.
not, if otherwise it is not possible. And
Mhm.
from what you're saying, I doubt she'd be willing for any invasive procedures for injection of any contrast.
Yes.
So, an 3 Tesla MRI at the time of active leak with prone position,
Yes.
and probably the radiologist would be able to help you better in this situation, I think.
Yes.
And generally they say that from what we have had an experience, the radiologists do say that a 3 Tesla MRI in prone position, if the patient is having an active leak at that time, then they have a high chance of picking it up
Okay.
uh, without any other protocol being followed or any contrast being there. Even just an active leak on a 3
Yes.
Tesla MRI, they are able to pick it up if there is active leak at the time of doing the MRI. So they place the patient in a prone position so that there will be active leak. So especially if they have lied down for some time and the reservoir is there, and if they lie down prone, so at that
Yes.
time, if they have an active leak, they are able to pick it up. So that would be one option.
Yes.
Otherwise, you definitely, because transcranially, we already approached the patient. I mean, transcranial surgery has already been done. We definitely have to go on endoscopic and do an exploration to see the site of defect.
All right.
Because 3 months she's already been on conservative management, so there is less chance of the leak resolving by itself after this
Okay.
point.
Oh, all right.
Yeah.
Thank you. I think those are good. Those are good ideas. I think we can try that the next visit she
Yeah,
comes.
please just talk to your radiologist because they have had some success here doing that. So maybe they'll definitely know better on what exactly can be done. But we've had some success doing that with certain patients here. So you can definitely talk to the radiologist there and try it.
Okay.
Now,
All right. Thank you. Wonderful
thank you.
lecture.
Thank you. Thank you so much.